said, "From what you're telling me, it sounds like she just needs to be locked in a psych ward and take antipsychotic medication." And, you know, not our daughter. It just didn't sound right. She was normal a month ago. And so at this point, we looked around, ultimately found a physician in a neighboring state. She got IVIG, and 4 days later, her symptoms were gone. And I realized at that point that I had to do something with this information.
I'm really excited about our next talk. Very, very excited about this topic, which is just simply not prevalent enough in mainstream psychiatry. And so many young people, but also even older people, can suffer for years and be treated with endless cocktails of psychiatric medication that don't work. Undiagnosed PANS and PANDAS can really lead to a revolving door of psychiatric treatment at best and tragic outcomes at worst, given its potential impact on suicidality. So it is imperative that we all understand more about how to diagnose and treat it. So I'm really thrilled to welcome Dr. Scott Antoine, who is going to talk about this really important and I think misunderstood or not understood enough topic. He completed his undergraduate training at the University of Scranton, his doctorate at the Philadelphia College of Osteopathic Medicine, and his emergency medicine residency and fellowship at Albert Einstein Medical Center in Philadelphia. He served 7 years of active duty in the U.S. Army as an emergency physician, followed by a practice as an emergency physician at St. Francis Hospital in Indianapolis. In addition to his board certification in emergency medicine, he achieved board certification in integrative medicine through the newly formed American Board of Integrative Medicine in 2016. He also holds certifications in functional medicine through the IFM, or Institute of Functional Medicine, and A4M. In 2013, his daughter developed pediatric acute-onset neuropsychiatric syndrome, or PANS. He and his wife, Helen, who is also a functional and integrative medicine physician, were able to shut off the immune response, treat the infections and toxins responsible for her PANS presentation, and bring her to full recovery. After his daughter recovered from PANS, he knew his specialty had found him, and since then he has refined his process and helped hundreds of children recover from PANS and PANDAS. In 2019, he successfully lobbied the Indiana legislature and helped pass a law which prohibits insurance companies from denying coverage from medical care, including IVIG, for children with PANS and PANDAS. Also, I understand that you are writing a book, or that you've written a book. Can you tell us a little about that, Dr. Antoine? And just welcome. I'm just thrilled to have you here. And I think this is such an important topic. And I know that you're writing a book for physicians. And so tell us when that will be available and what it's called. And thank you so much for being here.
Thank you very much. I really appreciate it. So my book is called The Comprehensive Physician's Guide to the Management of PANS and PANDAS. And it is going to be available January 30th, 2024. It's actually available right now on Amazon and other online booksellers for pre-order.
Dr. Antoine is going to be talking to us about PANS, PANDAS, the role of infection and toxin-mediated neuroinflammation in mental health disorders. So thank you so much, and I look forward to hearing it.
I have a daughter. Her name is Emma, and she is about 21 now. When she was 12, she came to us one day and said, "I don't think God likes me very much. I think I'm a bad person." And this was kind of strange coming from her, and we didn't think much about it. We had 5 kids at the time, and kids do strange things sometimes. So soon after, though, she came to us, and her hands were raw. She'd been washing her hands compulsively. She really lost the ability to get to sleep normally, and she had been a really compliant, sweet girl, and had just absolutely had rage episodes, kicked the door off the hinges to our bedroom twice, and she was about 83 pounds or something at the time. And we really weren't sure what was going on. My wife, Ellen, and I had both been physicians for about 20 years at this point. And so we tried to call the pediatrician, didn't really get a call back. And then Ellen came to me one night, a few nights later, and said, "I think I know what's wrong with Emma." And she gave me a few articles about PANDAS. I started reading and said, "That's exactly what she's got." So I I felt a little better at that point, called a few colleagues at a tertiary care pediatric hospital here where we live, and was met with the idea that PANS and PANDAS don't exist and we can't help you. So we hit the books, looked again, found a physician in New York, and I'm in Indiana. And so Ellen and Emma traveled to New York, and he took one look at her and said, "You're exactly right. This is PANDAS, and she really needs IVIG." So they came back. I called a pediatric neurologist here thinking, well, now we even have a treatment direction to go into, because I knew he gave IVIG for children with other disorders. And he said, "From what you're telling me, it sounds like she just needs to be locked in a psych ward and take antipsychotic medication." And not our daughter. It just didn't sound right. She was normal a month ago. And so at this point, we looked around, ultimately found a physician in a neighboring state. She got IVIG, and 4 days later, her symptoms were gone. And I realized at that point that I had to do something with this information, that I couldn't let this happen to anybody else, especially as physicians. I can only imagine if we hadn't been physicians, we wouldn't have probably gotten anywhere. So that's when I realized my specialty had found me. And that's how I come to you today. Okay. So I have no pertinent conflicts of interest to discuss. So in this presentation, you'll learn the definitions, of course, of PANS and PANDAS, some common presentations and current diagnostic criteria, the role of molecular mimicry in the development of autoimmune diseases. And if you remember one thing from this talk, it might be that. If you remember two things, it would be molecular mimicry and stay curious. Maybe those would be my two main points. You'll also learn, though, about the concepts of immune dysregulation in PANS and PANDAS, what may cause those. You'll learn about laboratory and radiology testing, the role that it plays, common infections, toxins, and stressors which may precipitate flares in these children. And the 4 areas that we've found in our practice have to be addressed by parents and physicians to successfully treat PANS and PANDAS. So some quick definitions. PANDAS stands for Pediatric Autoimmune Neuropsychiatric Disorder Associated with Strep Infection. PANS stands for Pediatric Acute-Onset Neuropsychiatric Syndrome. You'll also hear me talk about toxins, which are natural poisons from the environment. Think about venom, mycotoxins, things like that. And toxicants are man-made poisons, such as industrial chemicals, heavy metals, things like that. Some myths. First of all, when this is mentioned online in physician groups on Facebook or the like, you'll hear, PANDAS may exist, but it's very rare. Not so. The concepts are new somehow, or were invented in the 1990s when the original articles came out. Also not true. There is no scientific evidence that infections can cause neuropsychiatric symptoms. Not true. Toxin and toxicant exposures don't affect the immune system or cause neuropsychiatric symptoms. Other myths. Psychotropic medications are the only way to treat people with psychiatric symptoms. Or once children with PANS and PANDAS are diagnosed, they're destined to have flares just for the rest of their lives. It's just the way it is. And finally, the diagnosis and treatment of PANS or PANDAS is not evidence-based medicine. We'll spend a little bit of time on that, what that means. So in terms of evidence, I've sent my references for this talk to the folks at PESI, and they should be forwarding them to you. It's about 300 peer-reviewed articles. So here's a roadmap for what we're going to talk about today. So step 1 is we're going to discuss the history and science behind PANS and PANDAS. Step 2, the diagnosis of PANS and PANDAS. Step 3, some evidence-based testing recommendations I have for you in PANS and PANDAS. And then step 4 is evidence-based treatment in PANS and PANDAS. So roadside stop 1, let's talk about the history and science behind PANS and PANDAS. As many of you probably know, the immune system gets involved in things when you have PAMPs, which are pathogen-associated molecular patterns. They act as triggers. They are actually proteins on the surface of bacteria, for example, that act as an alert or alarm to your immune system. So innate immunity starts first. This is very nonspecific. It begins with barriers like your skin or mucus or diarrhea if you have an infection. Then inflammatory cytokines, chemicals are released. Natural killer cells come, and they are responsible for apoptosis and viral infections and cancers. And then phagocytes come to phagocytize or eat bacteria. Then we have adaptive immunity, which is acquired immunity. It's specific to the particular pathogen. It takes a bit to start working. It's mainly accomplished through T cells, which is called cell-mediated immunity. We have killing cells, T helper cells, Tregs, and then B cells, which produce and secrete antibodies, IgE, IgG, IgM, and IgA. They each do a little bit of something different. Antibodies bind with the antigen or the particular pathogen and then release a lot of chemicals and messengers, call the rest of the immune system in. And then they all pile on. So an immune deficiency can result from a defect in any of the steps, as well as other steps. Autoimmunity is when you have an immune reaction to the self and tissue damage. There seems to be a genetic risk, of course. We know that certain autoimmune diseases are genetically common. And then mechanisms. So the intestinal and cutaneous microbiome plays a role, as well as increased intestinal permeability. Those two things plus the genetic risk are required. You can also have induction of autoimmunity by bystander activation. So an infection of some type stimulates T cell activity, which causes some damage in neighboring tissues. And then ultimately you have this concept I spoke about initially about molecular mimicry. So molecular mimicry simply means that some pathogens have a molecular appearance that is similar to our own tissues. In 1995, there was a great article in the American College of Rheumatology journal, which explained, it was called Mechanisms of Autoimmune Disease Induction. Because, we tend to think, and I certainly haven't heard this since 1995 until I started digging into this literature, we tend to think autoimmune diseases, although they may be genetic, may just kind of be bad luck. You just kind of get lupus or MS or something, and there's not a lot you can do to prevent it. There may be some treatment options. But this particular article discussed molecular mimicry and said microbes and mammalian cells share T cell epitopes. They share proteins. And they mentioned that microbial infections could alter antigen processing and presentation to promote cryptic self-recognition. There's your autoimmunity. They said there's some immunogenic cross-reactivity between microbial antigens, proteins, and self-tissues by serum antibodies. And they mentioned this has been demonstrated in many situations in both humans and laboratory animals. They cited many additional papers, including one from 1964, which spoke about shared antigens between a parasite and the human host. So, how are streptococcal infections related to autoimmune neuropsychiatric disease? We're all familiar with group A beta hemolytic streptococcus. Strep pyogenes is the other name for it. We know that it causes a strep throat, pharyngitis, can cause skin infection, cellulitis, including perianal strep, and it can cause sepsis or bloodstream infections. So those are the infectious presentations. There are also toxin-induced complications, scarlet fever with the rash, scarlatina rash. That's a toxin-induced complication. So is streptococcal toxic shock syndrome. Then there are these non-suppurative complications. One of them, post-streptococcal glomerulonephritis, which can lead to renal failure, and then rheumatic fever. Throughout this presentation, you may notice some things that are in yellow, and those are to help you follow a thread through the presentation and see how all these things are linked together. So rheumatic fever occurs rarely now. If it does, it's between the ages of 5 and 15. Actually, Hippocrates discussed something that sounds like rheumatic fever in 400 BC. So in acute rheumatic fever, there may be a delay from strep infection to the symptom onset from 1 to 5 weeks. It's a clinical diagnosis using the Jones criteria. In most cases, they state there should be a preceding positive throat culture, rapid strep antigen, or an elevated ASO or anti-DNase titer. But since there's a delay in presentation, these tests could very well be negative. It presents with carditis, heart valve problems, polyarthritis, rash, subcutaneous nodules. We see those very rarely now, unless it's in a third world country, and chorea. Chorea is a specific type of writhing movement disorder. So the pathophysiology, it occurs due to a preceding group A strep infection from the skin, from the throat. There seems to be a genetic predisposition, and molecular mimicry by T and B cells is thought to be the cause. So what do we do to treat it? Antibiotics, beta-lactams like penicillin, cephalosporins, etc., seem to reduce the risk of acute rheumatic fever. And people are treated if rheumatic fever is diagnosed, even if the strep testing is negative. Current practice is actually prophylactic antibiotics, but depending on who you read, until age 21 or later, it may reoccur. Sydenham chorea. This is the type of movement disorder that's associated with acute rheumatic fever. It's also called St. Vitus dance. It's a movement disorder linked to rheumatic fever. It was discovered in 1600 by Thomas Sydenham, interestingly, and was first linked to rheumatic fever in 1802. It can be weeks or up to 9 months after the strep infection. The recovery can also be prolonged in some patients, and it can reoccur. And just in case you're wondering, it's actually Sydenham chorea, not Sydenham's chorea. People sometimes write it both ways. But Sydenham chorea, the etiology is known to be molecular mimicry. Antibodies to the strep carbohydrate react with neuronal structures. Antineuronal antibodies are present in 100% of patients with acute chorea, but 0% of healthy controls and studies. Tubulin is the neurologic target of these autoantibodies. MRI in these patients shows increased size of the basal ganglia versus controls. And CT and MRI studies have shown reversible striatal abnormalities, which then resolve after patients recover. PET scan shows some hypermetabolic changes as well in the basal ganglia, which resolve when people get better. So treatment of Sydenham chorea, similar to any other type of rheumatic fever, immediate and prophylactic antibiotics. And studies have shown significant improvements with antibiotics and steroids. And then because many autoimmune diseases are treated with IVIG, IVIG is given. It seems to sequester these autoantibodies. So IVIG results, there are some case reports in 2016 British Medical Journal. There was a 10-year-old girl, and if you read this case, she had been on Haldol, haloperidol, an antipsychotic, and valproic acid for 2 weeks. She had been on antibiotics for 5 days, continued to deteriorate, and the authors mentioned that she could barely walk or speak and couldn't feed herself. After she got IVIG, her symptoms were better at 4 days and gone at a month. In 2003, there was an article in the IDSA journal, Course Clinical Infectious Diseases, about a 15-year-old girl with incapacitating writhing movements from Sydenham chorea. And they said within 2 days of IVIG, the dysarthria and chorea showed marked improvement. The patient was discharged 4 days after the completion, and 4 months later, no neurologic symptoms. 2012, they did a study. 10 patients received IVIG, 10 received standard treatments. The outcome comparisons were tested by SPECT scans, clinical symptom scales, and symptom duration. There was a significant improvement in all 3 of these scales in the IVIG group. OCD, interestingly, Sydenham chorea is associated with OCD. It may be as high as 82% on initial presentation. In recurrent chorea, OCD occurs 100% of the time. It's also associated with ADHD-like symptoms, cognitive symptoms, specifically executive functioning issues, mood issues, and even psychosis. So what about autoimmunity and inflammation just with OCD by itself? There was an August 2019 review which talked about low-grade inflammation, neural antibodies, innate and adaptive immune abnormalities as well, and we'll talk about that a little bit later in the context of PANS and PANDAS. And what the authors said was, in some subset of OCD patients, autoimmunity is likely triggered by specific bacterial, viral, or parasitic agents with overlapping surface epitopes. Sounds familiar. In 1994, Dr. Susan Sweeto, kind of thought to be the originator, person that did the initial papers and initial studies on PANS and PANDAS, came out with a paper on anti-neuronal antibody disorders in the journal Pediatrics. And basically, she was talking about children with Sydenham, Chorea, Tourette syndrome, or OCD. She said, we hypothesized that neuroimmunological dysfunction secondary to anti-neuronal antibodies may result in behavioral disturbances. The antibodies in these cases were thought to be due to group-based strep. In 1997, the first article defining PANDAS was published in the American Journal of Psychiatry. Dr. Sweeto and her colleagues at the National Institute of Mental Health. They focused on strep as the pathogen. Now, they knew at the time they were seeing these presentations due to other infections, but strep is easy to eradicate typically in the person. It's easy to test, so it's easy to have a group to study. That may be why they initially just studied children with strep. And they coined the term PANDAS, of course, which we discussed and defined earlier. The diagnostic criteria at that time were OCD, so a DSM diagnosis of OCD or tic disorder, the onset of age 3 to puberty, an episodic course of symptoms, frequent dramatic symptoms that were sudden. They use the term foudroyant when they talk about the symptoms. And they said that there must be a temporal association with some type of strep infection. They also described neurologic symptoms such as hyperactivity, different movements, including choreiform movements. And I emphasize choreiform rather than chorea. If you found chorea, you would expect that it might be Sydenham chorea from rheumatic fever. But these were tic-type movements. In 1997, there was an article published on the first 50 patients with PANDAS, met the PANDAS criteria in the American Journal of Psychiatry. Same criteria as the last study. They described 50 patients with 144 episodes, so they were waxing and waning episodes. They also commonly noted they found separation anxiety, emotional lability, nighttime fears or rituals, cognitive deficits, and oppositional behaviors. So they MRI study was done in children with post-strep OCD and tics in 2000. It was the National Institute of Mental Health study, published once again in the American Journal of Psychiatry. And they did volumetric measurements with these MRIs and studied 34 children that met PANDAS criteria and 82 controls. And they found that the basal ganglia, the caudate, putamen, globus pallidus, was significantly bigger in controls. Interestingly, the same areas that were seen that were increased in Sydenham chorea. The initial studies of IVIG for PANDAS, sort of study by Dr. Perlmutter in 1999 in the Lancet, 29 children, they randomly assigned them to therapeutic plasma exchange, IVIG, or IV saline placebo. And they did baseline 1 month, 12-month scales, assessment scales for OCD, tics, depression, and overall function. They found no improvements in the placebo group over a 12-month time period. So these symptoms don't wear off. OCD was better in both IVIG and therapeutic plasma exchange. Anxiety, once again, improved. Overall function was improved, and the tics were better with therapeutic plasma exchange, did not get better specifically with IVIG in this study. 82% of the patients said they were very much improved at 1 year. Interesting study. I love the study. It's a very small in vivo mouse study, but this is what they did. They took sera from children with well-characterized PANDAS and matched controls, and they injected it in the striatum of mice in the brain, and then they did immunofluorescence microscopy to look for binding to these cholinergic interneurons, which are implicated in tic disorders. The PANDAS sera antibodies bound to 80% of these neurons. Healthy controls had less than 50% binding, and here's the hitch. After IVIG treatment of these children, they took sera again, redid the test, and the elevated binding resolved. So there's something about sequestration or removal of antibodies that IVIG is doing. Initial antibiotic studies were done 2002. They did a prospective study. The majority of the children had negative strep tests 3 months prior to their illness, which brought on OCD, and they were treated with beta-lactam antibiotics, of course, against strep. Immediate resolution was seen. 50% of the children had strep again, and the symptoms returned. It became controversial. So here's the thing. In the mid-2000s, some patients couldn't meet the criteria because they didn't have strep, and so they weren't treated. A lot of the studies done, as you've seen so far, were small, case-based, retrospective. And so people said, what people say sometimes to shut down an academic conversation is that's not evidence-based medicine, so we're not even going to go there. And really, the biggest thing is it's a different way to think about mental illness. So let's talk about that for a few seconds. In the 80s, late 80s, Dr. David Sackett discussed methods physicians should use to critically appraise the literature. He said, look, we shouldn't be witch doctors. We should sort of know what the literature says. And the original article coining the term evidence-based medicine was published in 1991 by Dr. Guyot, who was one of Dr. Sackett's mentees. And it said that physicians should read the literature, they should be critical and be familiar with study design, bias, statistics, so that they can determine whether they should use that information for their patients. Academic institutions championed evidence-based medicine as the scientific way to practice medicine. I was in emergency medicine residency at the time. We thought it was great. We wanted to wave the flag of EBM, and I still think it's great if you know what it is and know what to do with it. So in 1992, there was a JAMA article which further defined evidence-based medicine. And it said, people should rely on large, randomized, placebo-controlled, double-blind studies. And that became sort of viewed as the requirement to adopt anything in clinical practice. So that sounds good. But in 1996, Dr. Sackett published this article called Evidence-Based Medicine, What It Is and What It Isn't. And this is what he said. He said there's 3 things that are necessary for evidence-based medicine. You had to have the best available published evidence, meaning sometimes there might not be anything published yet, compassionate sensitivity to the patient desires and preferences, and clinical experience of the treating physician. And he said, good doctors use both clinical expertise and the best available external evidence, best available. And neither alone is enough. Without clinical expertise, practice risks becoming tyrannized by the evidence, for even excellent external evidence may be inapplicable or inappropriate for an individual patient. And he also said evidence-based medicine is not cookbook medicine because it requires a bottom-up approach that integrates the best external evidence with individual clinical expertise and patient's choice. And I would lay that before you, and I know you've heard it many times in this conference, and will continue to hear it, that the future of medicine is personalized medicine or precision medicine. And this was an article from another article kind of explaining and demonstrating how we have to consider the clinical state and the circumstances. In other words, if we have a patient, I was an ER physician for 30 years, if I had a patient coding in front of me, I would try almost anything to resuscitate that patient. I wasn't stopping to think necessarily every single time about evidence. The evidence for resuscitation in the hospital when people arrest is not very good, but we still do it because human life is precious. But then also considering research evidence, the patient's preferences, and then right in the middle, clinical expertise, which is the key to it all. But because the studies were small, because it was a different way to look at medical evidence, people said it doesn't exist. PANDAS doesn't exist. Despite very congruent patient histories, physiological and imaging data I talked about above, the studies listed above, and the clinical experience at many academic and community medical centers. But the sentiment that PANS and PANDAS don't exist permeated medical education. I mean, if you were a physician, you know that when you were going through training, much of your training was given to you by senior residents or attending physicians. You were told if someone has hypertension, you should use lisinopril, and I still use lisinopril. I've never actually looked at the studies for it, but it seems to work well in my patient population, and patients do well with it. And that's what a lot of medical education is about. So I think a lot of people that say it doesn't exist are just haven't ever looked into it. What about PANS? So in 2012, there was a paper from the National Institute of Mental Health with 6 clinicians with more than 400 PANDAS-type patients. They described symptoms, once again, that were very abrupt, ferocious, overwhelming. Some original and newer cases, though, were after other infections. So they then coined the term Pediatric Acute-Onset Neuropsychiatric Syndrome. But let's stop there for a second and say, can other infections actually cause neuropsychiatric changes? What does the literature say in the absence of meningitis? So Mycoplasma pneumoniae, Tourette's syndrome. There was a study in 2004 using antibody tests. 29 patients with Tourette's syndrome and 29 controls, significantly more elevated mycoplasma titers in patients with Tourette's syndrome. The Journal of Child Neurology, there was a case report in 2008, a 5-year-old that had pneumonia from mycoplasma, and OCD clarithromycin treatment helped resolve his OCD. There was another case report of two children with known vocal and motor tics, mycoplasma pneumoniae infection worsened the tics, it resolved with antibiotics. We also know that mycoplasma encephalitis, which is a different, more serious acute neurologic crisis, is known to attack the basal ganglia. In our practice, we've also found mycoplasma infection is associated with eating restriction, as is another tick-borne illness we'll discuss in a bit. Lyme disease, it's often called the great imitator. It affects many different body systems, and there's really a lot of symptoms associated with it. So we're told in residency, when in our training, that, of course, it can cause the rash, erythema migrans. Lyme disease, most people know, can cause Bell's palsy, joint pain, carditis, cerebritis in severe cases. But what else? If you look at the literature behind Lyme disease, there's many different case reports and published studies which discuss cognitive and memory issues, attentional issues, OCD, hallucinations, psychosis, depression with suicidal ideation. So we know as well Borrelia epitopes cross-react with human neural tissue from the brain, spinal cord, and dorsal root ganglia. That's how it causes things like a facial droop from Bell's palsy. Antineuronal antibodies can be seen in patients with persistent symptoms of Lyme disease after they've been treated. And we know central nervous system inflammation and glial activation is actually the mechanism behind a lot of these things. Early glial cell invasion and disruption of the blood-brain barrier has been noted as well. What about co-infection? So think of Bartonella henselae infection with patients with aggression and rage. Also Babesia duncani, we've seen a link with restrictive eating. There seems to be an explosion of Babesia duncani in the Midwest, in Indiana where I practice, as well as surrounding states from which some of our patients see us. And so I've put in some articles into the 300 or so references that I've sent you discussing the role of Bartonella and Babesia and co-infections as well as Lyme. Influenza has been linked to OCD as early as 1917 with the Great Flu. Dr. Konstantin von Economo described this concept of encephalitis lethargica. In 1920, some cases with chorea were noted, and there were similar cases described of people that had the flu in 1987. They noted involvement of the basal ganglia, spoke about OCD. No organisms and sections from the original patients in the 20s were ever found in the brain, which suggests if there is a problem in the brain, it's an autoimmune issue rather than an infection. There also was described by von Economo a pseudopsychopathic variant, and he said children with this variant had a wide variety of behaviors which were regarded as aberrant, delinquent, or even psychopathic. Many of these children were placed at the time in state institutions or prisons. Some were lobotomized. So we saw some complications of influenza, neurologic complications in 2009 during the H1N1 outbreak. COVID, we know that there are neuropsychiatric symptoms related to COVID. It may be due to the body's response to infection. There likely is also some coagulability behind that. We know inflammatory cytokines are increased during acute infection, and there's some blood-brain barrier permeability issues due to increased cytokine-induced brain damage. There was a retrospective study actually in Lancet Psychiatry in 2022 over 1.2 million patients. And they said that patients who had COVID were at significantly increased risk for psychosis, dementia, cognitive deficits, and epilepsy over the 2-year follow-up period of the study. We've seen minimal flares from COVID in our practice. Thank goodness. I thought it would be horrendous. I think we've seen about 2 patients which had their initial onset after having COVID. So over 90% of adults are exposed to Epstein-Barr virus. It may be minimally symptomatic as a young child, so you don't have to have mono as a teenager to have been infected. Anxiety and psychosis have been seen without the typical sore throat fever. Some long haul symptoms in COVID patients, in our experience, are often due to EBV reactivation. There's also a well-known link between autoimmunity, EBV, and multiple sclerosis. Chlamydia pneumoniae. There's an increased odds ratio, look at that, of schizophrenia in patients with chlamydia pneumoniae, 9.43 odds ratio. And chlamydia pneumoniae uses monocyte migration to breach the blood-brain barrier. And this has been found in endothelial tissue samples taken from patients with Alzheimer's disease. It may be linked to multiple sclerosis as well. Toxoplasma gondii is an intracellular parasite that we test for. It can be seen from cat feces or soil or contaminated water. You have 2.5 times the risk of OCD, 2.7 times the risk of learning disorders. It's also seen in schizophrenia, and more of those articles come out every day. So it all fits together like this. So PANDS is two parts. It's PITANS, which pediatric infection-triggered autoimmune neuropsychiatric disorders. That was the original term. And then that's further broken down into Strep and then other causes, mycoplasma, influenza, Lyme, etc. And then non-infectious causes, including environmental factors like toxins and toxicants, metabolic disorders, or stress, other issues. What about the toxicant connection? So environmental toxicants. The Archives of Toxicology has published articles about environmental chemicals and stated they can impair or stimulate, meaning trigger autoimmunity in the immune system. We know that there's hormonal dysregulation due to pesticides, specifically glyphosate. Heavy metals, even high normal levels, have been linked to various neuropsychiatric syndromes. The World Health Organization has noted, and even the CDC has noted in America, that there are no normal levels of lead in the body, even though there is a low normal level listed on some labs. Heavy metals can also adversely affect immune function as well as cause neuropsychiatric issues. So what about the toxin connection? So mycotoxins are really small organic toxins produced by molds. They affect human and animal health in many ways. They're directly neurotoxic and have been linked in studies to neuropsychiatric disorders. There was a study out of Tufts that I've referenced in my references. Numerous articles have shown that they impair the immune response and they may lead to a longer or more severe infection and also inflammation. Now, we've laid the groundwork for the science. Let's talk about how to diagnose PANS and PANDAS. It's a clinical diagnosis. Maybe that's the third thing I want you to remember. So the current diagnostic criteria from 2012, the abrupt, severe, sudden onset of OCD or restrictive eating, although I'll tell you, most parents who look back sometimes can see some things kind of rearing their head months beforehand in retrospect. So about 40% of cases may have a subacute or chronic type of slow presentation before you get the explosion of symptoms that really gets your attention. So those things, either restrictive eating or OCD, with the presence of at least 2 of the 7 following criteria: anxiety, emotional lability or depression, irritability, aggression, or severely oppositional behaviors. I almost wish that wasn't in there because oppositional behaviors, in my mind, from what I've seen, are the result of a scared to death person. So if you were scared to death of something and someone was trying to tell you it wasn't true, or your mind was playing tricks on you, or don't worry about it, or trying to make you do something that you're uncomfortable with, you'd get pretty frustrated and pretty irritable in a hurry. Behavioral developmental regression, deterioration in school performance, sensory and motor abnormalities, sensory sensitivities, somatic signs and symptoms, and it's the big asterisk, not better explained by any known neurologic or medical disorder like SIDNAM, chorea, lupus, tumors, CNS infections, etc. So to make sure that it's not better explained, there are times, not all the time, but times when you need an MRI, you need CSF studies, you need an EEG, an echo, or specialty consultation. So remember, most children with this are extremely ill with extreme compulsions. If your child doesn't like to eat broccoli, that's not an eating restriction. That's a normal kid. So we tend to throw around the term in popular society, OCD. I'm so OCD, I check my clock twice before bed. That's not OCD. OCD is extremely uncomfortable for people. So fears of contamination, hand washing, checking and rechecking, repeating magic words, or parents, they may tell their parents they have to say things in a certain order or a certain way or answer them a certain way. Religious thoughts or sexual thoughts are common, particularly difficult for parents. Children may talk about having sexual thoughts about the opposite sex parent or a sibling or a teacher at school. I always tell parents, don't push to hear the specific content. It doesn't matter. If they're having this type of OCD and these thoughts are coming, the specific content, the child may be reluctant to tell them. It's fine. This is a picture of my daughter Emma's hands at sort of the height of her OCD. You can see she's just absolutely raw from washing her hands. Also, severely reduced intake. They may have thoughts of choking, and sometimes I will send these kids to GI for a scope. Certain textures can be an issue. Hospitalization in a feeding tube may be needed in severe cases. Anxiety is often associated with OCD. Depression, the mood can change suddenly, be really volatile. Suicidal thoughts may be common. We haven't had anyone with a serious attempt or completion of a suicidal act. They sometimes will try and jump out of a car or undo their seatbelt in the car, but it seems to be more to get at their parent than actually do the thing. Irritability, aggression, as I said, which may be OCD driven. Developmental regression might be baby talk or selective mutism or new stuttering, and deterioration in school performance can be seen. Memory issues can be seen, but not delirium. This was a patient of mine. This on the left is freehand drawing before she got sick, and on the right was her best attempt to draw a pig after she got sick. You can see it's quite a difference. Tics, sensory issues. So tics, facial tics, sometimes mouth opening tics, or shrugging shoulders, throwing the head back, squinting tics of the eyes we can see. Clothing aversion, sensory amplification. Parent will be trying to put socks on them, and they'll just keep saying, it's not right, it's not right. Sleep disturbances, often they want to sleep with the parent. More often they want a parent to sleep in their bed. Enuresis, urinary frequency can occur in a potty-trained child. Cautions, so refer out and think beyond PANDAS. If you have a child that's got prominent delirium, psychosis, encephalopathy, or progressive decline, memory impairment, if things are progressively getting worse, certainly if you would see seizures or a movement disorder that's not consistent with tics. So in 2013, the PANDAS Consensus Conference occurred. A large group of physicians from many different academic organizations, many different fields, confirmed the clinical criteria. They also found increased incidence of psychiatric disorders in OCD in families and autoimmunity, a 10-time increased risk actually of OCD and tic disorders in family members, and an increased risk for rheumatic fever. So physical exam pearls, vitals and hydration status, of course, an eye exam for Kaiser-Fleischer rings, palatal petechiae looking for tonsillar exudates or erythema, tics, murmurs, evidence of hand washing or perianal strep. So these are Bartonella-associated cutaneous skin lesions, violaceous striae. These certainly don't look like stretch marks, which commonly they are blamed upon. And if you look, the best literature, there's a little reference down below. Dr. Breitschwer did fantastic literature, and they actually biopsied these and then did advanced microscopic techniques, which demonstrated Bartonella in the lesions. And interestingly, unlike stretch marks, when we treat people, these tend to resolve, either lighten or completely go away. Romberg exam. You should not have piano playing finger movements if children are over 8 years old. You may see normal or depressed reflexes, and then writing or drawing or copying figures can help you figure it out. They often appear anxious, deer in the headlights, tremulous, hyperreactive, tearful, and really withdrawn and hopeless. So what do we do in terms of testing? First of all, we may need testing for 3 reasons: to rule out other diagnoses, to give you an initial direction, or to guide the trajectory of your therapy. Remember, no testing rules in or out PANDAS. Many patients end up at our practice and they were told by a physician who saw them, your child's ASO titers are normal, so it can't be PANDAS. That's just a misunderstanding of the disorder. So MRI, EEG, of course, other things if needed, specialty consultation. So we typically do a CBC, a CMP. The C-reactive protein and ESR are very, very rarely positive. I really don't do them. Maybe 20% of the time they would be positive. Serum copper and ceruloplasmin to look for Wilson's disease. Iron and ferritin, thyroid tests and antibodies. Also, we do nutrient testing, homocysteine levels to look and see the methylation status. About 40% of these kids have a positive anti-nuclear antibody. It doesn't mean they have lupus or any other scleroderma. It's an indication of autoimmunity. Immunoglobulins, about 48% of them have low immunoglobulins in some field. Celiac antibodies and genetics, MTHFR testing. We also test for vaccine responses in children who've been previously vaccinated. If they're not making antibodies to any of their positive titers, it may be an indication of a selective antibody deficiency, which can help you get IVIG covered. So autoimmune encephalitis panels. There are conventional panels. That's what we typically do. And then there's the Cunningham panel. And you'll also hear people say this must be done. It's required for diagnosis. It tests for antineuronal antibodies. It's a good test. It's got 88% sensitivity and 83% specificity according to their website, which means it's falsely negative in about 12% of cases and falsely positive in about 17% of cases. It doesn't really change treatment or predict overall outcomes. It's about $900, I think, not covered by insurance, so it's not a test I do. Heavy metal testing, blood or 24-hour urine testing can be done. Hair and urine testing is available but not standardized. There are various companies that do this testing. I really don't test for glyphosate and other toxicants because it doesn't change treatment. Urine mycotoxin testing, we do. C4A and TGF-beta testing can be done through blood, but it can be thought of as a trend. It's not diagnostic of anything. VCS testing is impossible with children, rather unreliable in adults in our experience after several thousand adult patients. And we found no utility for mold antibody testing in our practice. The home should be tested, of course, that's another discussion. So infectious disease testing, we do testing for strep, obviously, throat cultures if there are symptoms, mycoplasma antibodies, and we do EBV antibodies with an early antigen, toxoplasma antibodies, chlamydia antibodies. What about testing for tick-borne illnesses? Shouldn't we just test for Lyme if we live in a Lyme endemic area? We've all been taught that, right? Just don't test if you're in the middle of wherever. So to that I say, dogs don't go on vacation. So a great study was done. They compared Lyme serology testing from veterinarians to a topographic forestation map of the United States. And you can see these are areas where Lyme has been reported. I would argue that the little white stripe in the middle is just places where people don't test for it. Because it's been identified in every state of the United States except Hawaii, probably because no one's tested. So two-tier testing has a sensitivity of somewhere between 30 and 50%. That's standard testing that would be recommended. Immunoblot testing and culture-enhanced PCR is much, much more sensitive for Lyme, as well as tick-borne relapsing fever, Bartonella, Babesia. All of these things should be tested. Co-infections actually are the rule rather than the exception. You can do RNA testing as well to reveal if infections are active. So T-cell testing, there's various companies that do this, tests interferon gamma and interleukin-2. They can demonstrate whether an infection you're seeing is active. They have a sensitivity of about 80%. They're available for various tick-borne infections, not all of them, EBV, mycoplasma, chlamydia pneumoniae, and I think COVID. We find it useful to track progress. Finally, evidence-based treatment. So there are 4 vital components I tell parents. You have to find and eliminate infections, find and remove toxins, re-regulate the immune system, and break the neurologic loops. So we talked about testing, now for treatment. So empiric antibiotics are usually indicated initially and for a flare. The duration can be prolonged, often 3 months of therapy. We often see patients who have been given 10 days of therapy or a Z-Pak for 5 days and they're not better. Infections like these are often persistent because they live in biofilms, which can protect them from host immune responses and antibiotics. So resistance genes can actually be passed in biofilms from one organism to another. So we use broad spectrum digestive enzymes and serrapeptase to help disrupt biofilms. We also use herbals. They can shorten the duration of antibiotic therapy, and they're especially helpful for tick-borne illnesses and really necessary for mycoplasma. Studies have shown, of course, that antibiotics shorten flares. So testing can narrow therapy, change direction of therapy. Nystatin can help prevent yeast overgrowth while they're on antibiotics. Strep salivarius comes in an oral lozenge. It's not a scary kind of strep, but it's an oral lozenge as a probiotic that prevents strep adhesion to mucosa. So how should we choose antibiotics initially if we're not sure what they're infected with? So some clinicians may use beta-lactams, some may use cephalosporins. There's some evidence that clavulanic acid may have neurologic membrane stabilizing properties. Some clinicians can use azithromycin to start, although we're seeing such resistance to strep now, especially in the Midwest. You sort of have to decide. So there's growing issues with resistance, and azithromycin, of course, may interact with some psych medications they may be on. So solution we've come up with is the PANDAS initial antibiotic decision scale. So we scale this basically different characteristics that might make it more likely that it's a tick-borne illness or mycoplasma, or more likely that it's strep. And we use that to help guide initial therapy. So herbal products, things with a sweet base. There are some companies that make sorbitol bases for herbals. In general, if they're not, they're made in alcohol and they taste kind of like tequila and oregano. Not that I've ever had that, but I guess that's the best thing I can tell you. I've tasted all of them. Studies have confirmed that various antibiotics, there's some studies for most tick-borne infections done out of Johns Hopkins that confirmed, at least in vitro, some reactivity. Cryptolepis seems to work well with azithromycin for Babesia duncani. So tonsillectomy, of course, there's some parent satisfaction reports, there's some case studies, but the ENT and pediatric literature for preventing strep recurrence really only shows short-term benefits. There's some retrospective literature as well that shows that tonsillectomy may predispose patients to more respiratory infections later in life because that's lymphatic tissue, which is involved in B cell lineage. I may recommend it if I can't get their strep titers down and they're just sick and not getting better. Removing toxins and toxicants, so glutathione or N-acetylcysteine are helpful. Bitters or TUDCA can help increase bile flow, have a choleretic action. Binders are helpful. We use a combination of activated charcoal, humic and fulvic acid, and zeolites. We don't use cholestyramine. It's hard to take. It's gross. Kids don't like it. And it really only takes care of one type of mycotoxins. So how do we re-regulate the immune system? We use a lot of low-dose naltrexone. It's compounded medication, very safe, reduces autoimmunity. It helps with immune deficiency, so it's sort of an adaptogen. It may cause some stimulation at night, so you just move it to the morning, may cause some headaches, that's mainly in adults. Steroids, they can't be used long-term, as we all know. About 50% of our patients, anxiety gets worse, they get more aggressive, they can't sleep. IVIG, so we typically write if we use it, and only about 10% of our patients need it. It's given at an infusion center initially, and if they tolerate it, they can have it at home. You really need detailed protocol and orders. In the book I just wrote, I have a whole appendix on my sample IVIG orders, some tips and tricks for after IVIG to help kids recover, as well as some tips and tricks for getting IVIG approved, and a sample appeal letter that I use successfully. We discharge kids with oral steroids and Zofran in case they get a post-headache, but IVIG can be expensive and difficult to get covered. But multiple studies, not just the one from '99, show that it's very effective. How do we break neurologic loops? So this is fascinating, and it's the part I like kind of most. But ERP, exposure response prevention, outperforms medication in every children's study of both anxiety and OCD. It interrupts the intrusive thought ritual cycle. It really needs to be done every day at home, not just 1 hour per week. Our patients, we give them a video of the point system that they can use at home. I didn't invent it. And children do better when there's a reward or currency system. So this is my daughter on the left. This is Emma in the blue. She did an intensive outpatient program when she was recovering in Chicago, and this was kind of the final exam. They had to go out behind the hospital and put their hands in the hospital dumpster. Gross. It's gross. There's like a liquid puddle down below the dumpster. It's gross. And then she had to wait 2 hours to wash her hands. And I only stopped because I was taking a picture, but I did it too. After she recovered, we went to Six Flags in Chicago, and she wouldn't touch anybody. She was afraid she was going to get sick, or she would get other people sick and they would die. And I was walking along the park as she was recovering, and I looked up, and she had put her arm spontaneously around her mom, and I like just about wept. It was just like profound. So breaking neurologic loops. So SSRIs are marginally effective. They sometimes can increase appetite, sertraline specifically in restrictive eating patients. Occasionally antipsychotics are used. None of them are FDA approved for this indication. Patients we see often get worse with these medications, and I don't prescribe them primarily. Hypnosis, fascinating. In younger children, it can help with needle phobia. I use it quite often when they're going to get their initial blood draw. In older children, it's helpful for OCD and even tics. This is something I wish I could just do this all the time and maybe not do so much biochemistry. I had one girl who came in with selective mutism. She was 16, hadn't spoken in 3 years other than to her mom. And after one session of hypnosis, she walked out of the hospital talking. It was just absolutely just nearly fell off the chair. It may also help nocturnal enuresis. There's a website called keepingthebeddry.com. Fascinating hypnosis from a urologist. It's very, very effective for some of our patients. Hypnotic language. It's helpful really in all ages. I use it all the time. I try and have parents use identity cues and tell them never to tell their child that they're a PANDAS patient. It's like the worst thing ever. Give people an identity. It's not needed. Also, when their child starts getting better, I'll have them use the phrase, back when you were sick. Oh boy, back when you were sick, you couldn't sit in this chair and not wash your hands. And sometimes I'll say to kids, are your parents lying? Because they'll come in and say, I don't have a problem, like my daughter said when we took her for intensive outpatient. And so I'll say, oh man, I didn't realize your parents were liars. And usually that's enough of a hypnotic pattern interrupt. We also use neurolinguistic programming quite often. So other helpful interventions, nutrient replacement, which those are required to make neurotransmitters. I'm sure someone else will talk about that if they haven't already. Some dietary changes to decrease inflammation, only if they're not food restricting. NSAIDs, curcumin we use. Also probiotics. The microbiome trains the immune system, and some probiotics may remove toxins. I've told people before that I sometimes wonder when we give an antibiotic and see a result in 24 or 48 hours, if we're not killing the organism as much as we are altering the microbiome and altering the immune response some way. I think that's research for the future. Family counseling, very helpful. School support, I tell parents early. I also have in the back of our book another appendix about IEP and 504 information for parents, and also information for parents to deal with their family and their friends, to give them language to use to get the help they need and to explain what's going on with their child. So state campaigns to prevent insurance denials are in the future. Also physician and healthcare provider education. The book I wrote to physicians as sort of a love letter to the art of medicine, a love letter to other physicians. Because look, the patients come to me and they have the diagnosis. The parents know. They made the diagnosis before they ever get to me, in spite of maybe someone that they saw. We're all busy. Many of us are burned out. But I wanted to give people an evidence-based guide to diagnosis, testing, and treatment that's reliable, to effective treatment, so that they can help these kids. Because I can't be everywhere. I get requests from Australia, the UK, and I can't treat people in a foreign country legally. So it's my hope that it will be able to be used as a standard of care. And also immune modulators and targeted therapies. There are already people that are using rituximab and some other targeted therapies. I kind of look at that as putting the fire out acutely. There may be smoldering coals that then we have to take care of. But if you have an extremely ill child, maybe helpful. So I thank you. There's some contact information for y'all. And I think I have maybe 4 minutes for a question.
That's wonderful. Thank you so much, Scott. And thanks so much for the work that you do. It's just so important. So just a couple of questions. What would you do with a child with 4+ years past bullseye rash and Lyme disease and now OCD?
So if I saw that child initially, I would likely, we do intake with people. It's quite extensive. And then I will see them in the office, do a nutrition-oriented physical exam, do testing. That is a child, if they have severe OCD and are affected, I would likely start them on a macrolide antibiotic if there were no contraindications, and as well as work on inflammation, support the microbiome, also think about testing for toxins and toxicants. If you tested the entire population of the United States, probably 30% are positive for Lyme disease. And maybe 1% of those people have symptoms. So a lot of it, I think, has to do with the immune dysregulation. And so what we think happens in these kids is that the toxins and toxicants get on board, disrupt the immune system, and then an infection like Lyme or Bartonella or Babesia, which can be intracellular and chronic, then pops up to the surface, just like EBV seems to become reactivated after COVID. So I would do all of those things. And then when I have patients that say, I can't get there, I'm in Norway, I'll say to them, the very first thing you can do is make sure there's no mold in your house. Because there are some people, you fix that and get them in a clean environment, they rapidly improve despite not doing other things. So that's like my initial, like, if you're going to do nothing, do that.
Yeah, and I mean, that was a question also was, can you have PANDAS with only toxicants as opposed to infections, or are there always going to be both as triggers?
That's a super, super good question. I just had this discussion this past week with one of my staff members about that, because I had a patient who came up and had mycotoxins, as 100% of our patients do, 100% of the ones we've tested. But we couldn't find a positive. We did very extensive infectious disease testing and Lyme testing, like a ton of tests. We couldn't find a single positive, not even mycoplasma, nothing. And I looked at it and I said, these kids, and this child had low immunoglobulins, and I said, I think this is a child that's not making antibodies. I'm not sure, people have all sorts of neuropsychiatric symptoms with mycotoxins for sure. I'm not sure I've ever seen a classic presentation without an infection. I had one recently, and I think it was just the child wasn't making. So I'm going to do follow-up testing when we get their immune system a little bit re-regulated, and I'm going to retest and see if we have a positive at that point. I did start them on antibiotics, as I do most kids. When I got the results of that testing back, I did not stop the antibiotics because they've started getting better. So I'm like any port in a storm. Even if I'm just using the antibiotic to fix the microbiome, great. Whatever works. I'm an ER doctor, so whatever works.
Any specific treatment for the enuresis after eliminating as best as possible the cause?
So I'm not a fan of using monitors, bed monitors, where you would attach to the child's undergarment. When it's wet, it buzzes, and it doesn't hurt them, but it buzzes and whatever. So I've seen kids have like night terrors for days after that. The keepingthebeddry.com hypnosis course is super helpful. A lot of it ends up being everything else you're doing takes away the bedwetting or takes away the wetting in their pants, which my daughter had that as well. So everything else that you're doing kind of, yeah. But in reference to what that person said, maybe there was a hidden question in there that I should probably touch on is, please make sure the child doesn't have a UTI or vesicouretal reflux or something, because as I tell people, we're doctors first. So
completely. And then a final one, great information, especially on tick-borne diseases. Do you use IGeneX labs for testing?
Okay, so since you've asked, I can say, yes, we use IGeneX labs. That is sort of the primary testing. We actually just started doing a program with a company called Health Lab that helps get IGeneX run through insurance. It's significantly cheaper because I love IGeneX, but they're super expensive. But this company has resulted in savings of 40, 50, 60% off typical IGeneX panels. The panel we use is, I think it's called Tick-borne disease 2 or something. It's about $1,700, but patients are getting significant savings. But I found that IGeneX is the most valuable because it tests for types of Borrelia that are not tested by other types. Common testing through LabCorp and Quest, love them, use them all the time, but their tick-borne testing tests for strain B31 of Lyme. It doesn't test for B157 or any of the other Borrelia that's now exploding in the Northeast United States. So
amazing. Well, unfortunately, we're out of time, but I just wanted to say thank you. That was amazing, Dr. Antoine, and thank you so, so much. It's vital, vital information. Can't wait for your book to come out. And for everyone else, we will see you back in 15 minutes. So thank you so much.
Thank you so much. I really appreciate it.